Ladies and gentlemen, thank you for standing by and welcome to the COVID-19 Media Briefing Conference Call. At this time, all participants are in a listen-only mode. After the speaker's presentation, there will be a question-and-answer session. To ask a question during the session, you will need to press star 1 on your telephone keypad. Please be advised that today's conference call is being recorded. If you require any further assistance, please press star 0. I would now like to hand the conference over to your speaker today, Michael Schumer. Thank you. Please go ahead.
Thank you for joining us for the COVID-19 media call for September 23rd. We'll start today's call with a situation report from Minnesota Commissioner of Health Jan Malcolm. We'll also hear from MDH Infectious Disease Director Kris Ehresmann and MDH State Epidemiologist Dr. Ruth Lynfield. After that, we will open it up for questions from reporters on the line. With that, we'll now turn it over to Commissioner Malcolm.
Thanks, Mike, and good afternoon, everyone. These daily situation reports with reciting the numbers from around the world and the country and here in Minnesota have gotten seemingly kind of routine. But when you think about what these numbers represent and what they mean, it's sobering to reflect and not just have it seem like a rote thing. Globally, as of this morning, we're now over 31.6 million cases of COVID-19 and 971,000 deaths. In our United States this morning, we're above 6.8 million cases and have now crossed the 200,000 death threshold from COVID-19. Here in Minnesota, we're at 92,100 cases. This is an increase of 690 positive cases yesterday on yesterday's testing volume of 10,319 lab tests. We also have 6 additional fatalities reported yesterday, bringing our new total to 1,985 deaths in Minnesota from COVID-19 disease. 3 of these persons were in Hennepin County, 2 in St. Louis, and 1 in Itasca. This includes 1 person in their hundreds, 1 in their 90s, 2 in their 80s, 1 in their 70s, and 1 in their 60s. 3 of these deaths were among residents of long-term care facilities. 303 patients are currently in the hospital, with 148 in intensive care. As mentioned, the testing volume continues to increase, as does our new case count each day inexorably. The weekly change in cases is up 7.4% from a week ago today. During that same time period, testing is up 7.8%, which is an increase from 6.4% the week prior. The 7-day average testing positivity rate, which we focus on a lot, is 4.6%, which is a decline from the week prior of 4.8%. We've been below the 5% test positivity mark statewide for 12 days now, which is encouraging. But we do have a number of regions around the state that remain over 5% test positivity, which, as you probably recall, is a caution level for us for tracking the spread of the virus in our communities. With that, I'll turn it over to Director Kris Ehresmann for a further update.
Thank you, Commissioner. I'd like to start by just noting that we were made aware of a funeral that happened on September 9th in Martin County, in which 150 to 200 people were in attendance. Many attendees did not observe social distancing and masking. The memorial was comprised of the service at the church and an after-service luncheon at a private residence. And at this point, we have identified 33 cases with links to this outbreak, but we expect that there are probably more. We're also aware of additional cases linked to the church that held the funeral. There are affiliated churches that share staff. These are in addition to the funeral numbers, and there are 17 cases. And we just want to highlight that this incident points out the need for a layered approach to protection. COVID is a disease that tends to do its worst when people congregate in crowds, and keeping a distance plus masking plus avoiding crowds as much as possible is the best approach. One of them alone is rarely enough. Then a few weeks ago, I was asked about Halloween, and I felt like it was a little bit early to ask that question, but CDC has put guidance out, and so we wanted to make sure that we were sharing that with you. So no one will be surprised to hear that CDC says that many traditional Halloween activities can also be high risk for spreading viruses. They point out, however, that there are several safer alternative ways to participate in Halloween, and so we want to share those with you. But as you probably know, CDC emphasizes, and we certainly reiterate, that if you have COVID-19 or you've been exposed to someone with COVID-19, you should not be participating in any in-person Halloween festivities and should not give out candy to trick-or-treaters. The guidance from CDC is really not a do this or don't do that variety, but it's actually rather helpful. They break holiday activities out by risk category. And the information that they provide is quite detailed and is available at the CDC website, www.cdc.gov. So I'll give a couple of examples so as not to overwhelm us. But then the CDC website is a really great resource for additional details. So they break activities into high, medium, and low-risk activities. So low-risk activities might include carving or decorating pumpkins with members of your household and displaying them, or being outside at a safe distance with neighbors or friends to do the same. Decorating your house, apartment, or living space with Halloween-related items, or doing a scavenger hunt for children where they are given a list of Halloween-themed things to look for while they walk outdoors, admiring Halloween decorations at a distance. Having a virtual Halloween costume contest. Moderate risk activities would include participating in one-way trick-or-treating, where individually wrapped goodie bags are lined up for families to grab and go while they're continuing to social distance. We do recommend that if you prepare goodie bags that you would wash your hands with soap and water for at least 20 seconds before and after preparing the bags. You could have a small group outdoor open-air costume parade or party where people are properly masked and distanced at more than 6 feet. Just to note that although Halloween costumes often include a Halloween mask, that is not a substitute for a cloth mask. And then in terms of high-risk activities, CDC does recommend that people avoid certain higher-risk activities, which would include the traditional trick-or-treating, where treats are handed directly to children going door to door, or having trunk-or-treat situations where treats are handed out from trunks of cars. And, of course, crowded costume parties. In anticipation of sharing this information with you, I thought, man, I feel like the public health buzzkill, but really public health recommendations are not intended to ruin your fun, but rather to keep you safe. And it's actually the virus that's the buzzkill here. I also wanted to provide you with a quick data update. We want to talk a little about some upcoming data changes for our website, specifically for our hospitalization and ICU data. We've been collecting and reporting hospital data in multiple ways over the course of the pandemic. It's a big undertaking for both our staff and the staff at hospitals. As the pandemic has evolved, it's become clear that the two elements of hospital data that we feel are most important in our understanding of COVID are hospital capacity and disease severity. Hospital capacity data is currently collected by the State Emergency Operations Center and is intended to evaluate hospital surge capacity. This data looks at the number of people who occupy hospital beds in Minnesota. It's not dependent on residency, meaning we're looking at hospital beds occupied by Minnesota residents and non-residents, such as folks from bordering states who may need to be hospitalized here. These data are available on the Governor's Response dashboard and are updated every weekday. The hospitalization data on our situation update webpage was added early in the pandemic and was meant to portray the number of cases with severe disease requiring hospitalization and to track those changes over time. As we have learned more about what information is needed for the public and decision makers, we have learned that these data are not meeting the need they were meant to address, which is severity of disease. In order to best understand the severity of disease, we want to look at the proportion of cases admitted to the hospital. This is more useful than the number of people who are in the hospital at any given time. We currently provide data on the number of people in the hospital and in the ICU each day, although this is kind of combining two concepts, the concept of new admissions and length of stay. We do track and use data on hospital admissions by date to make decisions, and this information is what is posted on the governor's dashboard as one of the dial-back indicators. So at this point in the pandemic, it makes the most sense to focus on this measure. In order to provide the best information we have to describe what is happening with Minnesota in COVID, in order to provide the best information we have to describe what is happening with COVID in Minnesota, we'll be switching our hospitalization data to reflect these two aspects, severity and capacity. On Thursday, our situation update will shift to reflect the number of new admissions to the hospital and ICU for each day over the entire timeline of the pandemic. So although the shift will be on Thursday, it will provide data for the entire course of the pandemic. Next week, we will add additional data on hospitalizations to our weekly web report, which is updated each Thursday, to better describe what we know about cases who require hospitalization. One element of this will be length of stay for hospitalizations in ICU. As cases continue to increase, we are seeing our hospitalization numbers increase, further highlighting how severe this disease can be and how important it is that we all keep taking steps to prevent the spread of COVID. It is so important that you wear a mask, keep distance from others, and wash your hands. And I'd like to turn it over to Dr. Ruth Lynfield to talk about some issues that we're seeing with children.
Thank you very much, Director Ehresmann. I would like to give an update on multi-system inflammatory syndrome, or MISC. There have been 25 children that have been reported to the Minnesota Department of Health with MISC from May. There were 3 in May, 11 in June, 2 in July, 5 in August, and 2 thus far in September. This is a severe syndrome in children that is associated with fever and multi-system involvement, defined as 2 or more organ systems, and hospitalization. It is thought to be associated with SARS-CoV-2, and 88% of our cases had either a positive PCR or antibody to SARS-CoV-2, and the others had known exposures within 4 weeks to a confirmed case. 68% of these children were previously healthy. 60% required intensive care. All 25 had fever, and 84% had gastrointestinal symptoms. 75% had evidence of heart involvement, including many with abnormalities on echocardiography. None of these children are currently hospitalized, and fortunately, we have not had any deaths due to MISC in Minnesota. The age range has been 6 months to 16 years, with a median age of 4 years. Nationally, there have been 935 cases reported to CDC, including 19 deaths, and the cases have been reported from 46 jurisdictions. Black children and children who are Hispanic have been disproportionately affected in Minnesota, with 76% of our cases being Black or Hispanic. This is similar to what is being seen nationally, with 70% of missed cases being Black or Hispanic. To put the Minnesota numbers in perspective, though, we have had 25 cases of MIS-C out of more than 15,000 reported cases of SARS-CoV-2 infection in those aged 0 to 19. Although this is a rare condition, we do want parents to be informed and to seek medical care for their children if they have fever and GI symptoms, some other signs of rash or red eyes, and excessive fatigue. This is especially important if their child is known to have had COVID-19 or to have been exposed to someone with COVID-19. However, note that these symptoms can be due to other etiologies, so it is important for children to be evaluated. More information on MIS-C is on our website. At this point, I would like to hand the call back to Mike Schomer.
Thank you, Dr. Lynfield. Operator, we are ready to take questions.
Again, as a reminder, to ask a question, you will need to press star 1 on your telephone keypad. To withdraw your question, press the pound key. Please stand by while we compile the Q&A roster. Your first question comes from the line of Kate Bredetz from WTTOD. Your line is now open.
Thank you, Commissioner. We're seeing schools having to change gears from hybrid or in-person to distance learning. I know Brainerd hasn't said how many cases they had, but is there a certain number of cases or a percentage of students in a school where you say, okay, this is drastic enough to move to distance learning?
This is Jan. I will turn it over to Kris for a more thorough answer here, but just to make the point that, as we said from the beginning, with the release of the Safe Learning Plan for Minnesota, the framework really envisioned the need for flexibility and the ability to move between models, and we are grateful for all the work going on with educators and public health officials to consult on what is the right model. And as we've talked about before, there are many factors that need to be taken into consideration about what we know about disease prevalence in the community, the specifics of outbreaks that can be linked to a specific school. But I will ask Kris to chime in on just a little bit more about how that consultative process goes.
Well, thank you, Commissioner. Yes, we look at both the number of cases. First of all, let me just say that we have regional teams that work with schools within each of the regions. And as we're working with the school, we're looking at both the number of cases, the proportion of students who are out, as well as educators who may be out. And it really, varies by situation. And the reason I say that is because we've had some situations in which there's been a case who has exposed a significant number of the student body. And so although there may be a lower number of cases, because there are so many students who are out on quarantine, some schools have decided that it makes more sense for a certain grade level to perhaps go to distance learning because of that situation. So we're really working with the school and the district to evaluate their data. The other thing, too, is to acknowledge that while numbers make a difference, their school size is different. And so to just say that it's a fixed number of cases, that may not be appropriate for every situation. So we're looking at the number of cases, what proportion of the student body it represents, what proportion of the workforce, the staffing and administration, as well as what proportion of students or staff may be out because of exposure. So it's a wide range of things that we're looking at, and we're working with the schools to help them make the best decisions possible.
Got it. And just to follow up to that, we're really hearing this sense of urgency from experts about the rate of high schoolers and college students testing positive for COVID. Can you speak to that and something that, maybe one thing you want students and parents to do to help squash this trend?
Commissioner, would you like to start?
Yeah, I was just going to say, Kris, just to make a general comment and then ask you to chime in again. I think that thanks for the question. It really does kind of reinforce what we keep saying over and over again. I mean, again, schools, educators, teachers, administrators have worked incredibly hard to try to develop thoughtful plans for how to mitigate risks and when what learning model is going to be most able to be executed well in their schools. But we've said over and over again that what really matters is what's going on in the larger community and the degree to which, even for all the data that Kris and her team have on what's going on in the schools, we know that a whole lot of what's affecting the schools is what's happening in the broader community. And I know everyone on this call fully well understands that, but it's just another opportunity to remind people how absolutely important as citizens, the things that we are choosing to do and whether we are or are not taking those precautions really is having an impact on these transmission rates. So, Kris, back to you.
Oh, thank you. Yes, I think that, and I know Dr. Lynfield feels this very strongly too, so she may want to add an additional comment, but we're very concerned about what we're seeing with the data. As the commissioner said, what's going on in our communities, what's going on particularly in our young adult populations, and we're concerned for a couple of reasons. One is, as the commissioner said, our educators have worked very hard to create a safe learning plan, but that plan only works if we're all working together to reduce transmission. And so we're very concerned that with the high rate of transmission that we're seeing, that it won't be too much longer until we really have difficult decisions to make, or many schools have difficult decisions to make. So it's concerning at that level because of what it means for learning, but it's also concerning because the more disease we see, the more disease in the community, that starts to trickle into other areas. And we're starting to see some increases in our long-term care facilities. So we recognize that ripple effect. And so we want to not only preserve the opportunity for education in person as much as possible, but we want to avoid seeing this case growth impact other sectors. And Dr. Lynfield, do you want to add your emphatic comment?
I totally agree. We are extremely concerned, and this really is a time for all of us to work together and to recognize that we are all Minnesotans, and decisions that each of us make really does have impact on other people. And for us to really make it through this pandemic with a way that we can lessen the trauma on people, because each person that dies in our state was a person, was someone who was loved by someone who contributed to our community. And we have to work together in our communities to the best ability that we can to decrease spread. And this will inconvenience people. We know that. But we are in a pandemic, and we have to pull together to make it through. Thank you.
Thank you.
Your next question comes to the line of Emily Havoc from Care 11. Your line is now open.
Hi, thanks for taking my question. We're seeing quite a surge of cases in La Crosse County, and Winona County issued a travel advisory recently. What is your level of concern about an outbreak so close to the border and then so close to a college town in Minnesota? And I know that there's been some community testing in Winona recently, so a follow-up would be, do you have the results of that testing? Do you know what the impact of that activity is in Winona right now?
I'm going to ask Kris to take the primary answer on that. I'll just make the point that you would expect probably, which is just that this just illustrates again the difficulty of thinking that we can just take things on a state-by-state basis and manage this as successfully as possible. That what happens in other states certainly does affect other states, and we know that's true from Minnesota to other states as well. So Kris?
Yep. Thank you, Commissioner. I don't have the testing results at this point, but as the Commissioner said, yes, I mean, we see transmission going both ways, and when you have communities that are so connected, it makes a difference regardless of the state line. The virus doesn't care where the state line is. The virus cares where the people are gathering together. And so, yes, the increase in cases that we've seen in our neighboring states has been concerning to us. And as we've mentioned, earlier in our comments, we are concerned about the increases that we are beginning to see now in Minnesota as well.
Anything specific that you'd say to people who live along that border and regularly travel either for work, for leisure? Is there a recommendation you're giving right now?
I think that the point we want to make is that if you're leaving your house and you're driving to work in La Crosse or La Crosse to Winona, back and forth, and you're in your office and you're wearing a mask, that's not the concern. It's when people are in groups gathering together. So I think that's what people have to keep in mind, is that we know that we have a great deal of transmission occurring in these locations. And so it's all the more important that people are attentive to the fact that you want to, consider those layers of protection, avoiding large groups, masking, and social distancing.
Thank you.
Your next question comes from the line of Jeremy Olson from Star Tribune. Your line is now open.
Hi. One off-topic question slightly, although it kind of relates to Halloween, is, what's the current thinking about transmission through hand-to-hand contact? Or even contact, you go to a store, someone who's infected touches a box, then someone else touches that box. There was a lot of concern about cleaning surfaces and things like that earlier in the pandemic. I haven't heard as much discussion about that now. What do we know about that as a source of transmission?
Ruth or Kris, could one of you lead on that one?
Ruth, do you want to start?
Sure. So, Jeremy, thank you for the question. What you're describing is fomite transmission. That's how we refer to it scientifically. And we do think that if a surface has a lot of contamination on it and someone touches it and then touches their mouth or their eyes, their nose, there certainly is the possibility for transmission. And that is why we do continue to recommend that people clean very carefully and assiduously and frequently. That is a component of our guidance, and it is something that we were talking about schools earlier. That surely is a big component of their plans as well.
Follow-up.
Go ahead. Having said that, though, we do think that most transmission is the within 6 feet, and particularly if someone has coughed on you, we think that is a more common source. And we do know that there have been cases of, quote, airborne. We see this especially in aerosolized generating procedures in hospitals, but we've also noticed in certain outbreaks that there does seem to be a component in certain situations.
A related question deals with the, you discussed the funeral, you've discussed group events. We've talked about bars and some of these large group events. I just wondered if you could put that in proportion or context for me. How much are these large group events the engine driving our COVID case growth right now? Are they kind of an exception? They're just part of, or they're a piece of the puzzle, or are they kind of the big piece that's driving a lot of what's going on?
Kris, would you like to take that one?
Sure, thank you. I would say that they are a large driver of what's going on, because with each event, you have multiple cases who then go on to, spread disease to multiple other people. I think in a positive way that isn't positive, they're very efficient. They're a very efficient means of transmission. And so, if I have COVID and I exposed you individually, yes, I've exposed someone else, and certainly that's problematic. But if I go to a large gathering and I have the opportunity to expose 100 people or 150 people, that is so much more efficient. And I don't mean that in the positive manner, but I mean that contributes much more to much greater spread. And then, with each individual, they move on to share with that many other people. And so, yes, these are significant events, and that's why in our media briefings over the last number of days, we have been talking about the concerns that we see when we see our community transmission increasing, because we know that the effect of these events is now meaning that we've just got more people in the community who are infected and can spread. So, yeah, they are concerning. They themselves may not account for all of our cases, but when you start to look at what impact the spread has on with the second and third and ongoing generations, they make a big difference.
Thank you.
Your next question comes on the line of Catherine Richard from Minnesota Public Radio. Your line is now open.
Hi, I was hoping you could clarify a few things about the funeral you mentioned at the top of the hour. You said, I think, 33 cases. Is that just firsthand transmission, meaning people who got it at the event? And were any of the priests contagious, or are you tracking any cases back to them? I'm just wondering if that would have been part of the transmission.
Yes, so the 33 cases are all directly linked to the event. So in other words, they all attended the funeral. And we are aware of some staff who have been infected, although I don't want to get into much more detail. I want to make sure that we're protecting people's privacy. But yes, we are aware of staff as well as, cases that are directly linked to that event.
Okay. And I have a question from our education reporter. She wants to know, when it comes to reporting, like the school districts or schools reporting to parents about a case, do you have any guidance on that? Because we do know some districts are not telling parents if it's a student or a teacher, or they may not be telling parents if it's isolated in one school as opposed to, all parents in the district.
Our guidance related to sharing information is our highest priority is to make sure that those individuals who were potentially exposed to a case of COVID have been notified. And so when we work with schools and school districts, we provide them with information to share specifically to those individuals who may have been exposed. It doesn't matter if it was a student or a staff member, and we don't provide that. It's not necessary for anyone to know that. And again, we want to be very cognizant of data privacy. Then our recommendation would be that information, there could be a courtesy notification to, say, the school. So in other words, if it's a particular classroom or group of students that has been exposed and received that information, that you can notify the rest of the school in a courtesy manner to say that there was an individual in our school, that type of thing. So that's what we recommend for transparency. I do think it's important to keep in mind, however, that everyone should be thinking about COVID not just because they got a letter to say that someone in their district or their school may have tested positive, because of what we've been talking about the very high levels of community transmission that we're seeing, unfortunately, across the state.
And sorry, if I may, just one more quick clarifying question on the funeral. I understand that the schools in that area, the Fairmont district, for instance, and in the Truman schools as well, they've had to make some changes both to their learning model, but just also staffing issues. Have you been able to make a direct line between that funeral and those changes?
We're certainly, our team, as we've talked about these teams, they're consulting with those districts. And as we've talked about on other calls, we look at what's happening in the community as well as what's happening in the school. So we want to make sure that we're both considering community transmission as well as what's going on in the school. And if we have a situation where the transmission is really concentrated, we've had outbreaks now in prisons, we've had outbreaks in long-term care. If we recognize that the concentration of cases is in a location that may or may not have a strong impact on the school community, that's taken into account too. So I think it's fair to say that there's been transmission within those communities in addition to what's going on here.
Okay, thank you.
Your next question comes from the line of Jerry Burns from Mesabi Tribune. Your line is now open.
Hi, I'm wondering, with just the big influx of cases we're seeing in St. Louis County and long-term care facilities, if the state is looking at, or if they're considering having a quicker trigger on maybe changing guidance for those facilities, considering how at risk the residents are.
Kris, I'll ask you to comment on that one again too. This is Commissioner Malcolm. I think, in general, our guidance is very much tied to the level of cases in a facility. So, have to perhaps get a little more information on what's behind your question about changing guidance. But certainly that we keep reinforcing that continuing to protect the most vulnerable in our communities, given the high degree of community spread, is just another reason why we just keep saying to people, even if you don't personally feel at great risk from COVID, be aware of the ways in which you can impact your loved ones and your community. But in terms of specific guidance, Kris, you want to speak to that, or perhaps ask for clarification on the question?
Right,
I
that's
can
what I
clarify
wanted.
on that.
What did you? Oh, go ahead.
Just on the clarification part of that, is it possible that if things are looking bad in long-term care facilities, as we saw in the beginning of this, would the state consider pulling back some of that local control and going back to more of a blanket coverage, as we saw earlier?
Yeah.
Sorry, I asked that really awkwardly, so my apologies.
No, I think I understand what you're saying, and that is that, initially at the start of the pandemic, we had broad overarching guidance of no visitation, and then we have since moved to guidance that focuses on what's happening locally to make decisions. And as the commissioner said, we look at both what's happening in the community as well as what's happening in the facility. And so certainly, we would work with a facility to help them make some of those determinations. As we talked about earlier, we have COVID case managers that work with each of the facilities. I think one of the things that we're thinking about now, we're looking at, is that the Centers for Medicare and Medicaid Services, CMS, has put out some new guidance as well related to visitation. And so that is something that our team is looking at. along with partners in the industry so that we can provide, the best guidance to all of our stakeholders, but that guidance, make some changes in allowances for visitation that will kind of supersede anything that we have put out. So we're currently looking at that. So I think what we try to do is not only have we put out general guidance, but if a facility is in a unique place, we certainly have teams that will talk to them about what's going on in their community and in their facility and help them make decisions.
Okay, thank you.
Operator, we have time for one more question.
All right, your next question comes from the line of Kris Megan from Pioneer Press. Your line is now open.
Thank you. As we approach the 2,000 death mark, I was wondering if the commissioner or one of you could just reflect a little bit on what we've learned since this pandemic began when it comes to how fatal this disease is and what some of the biggest sort of contributing factors are to someone who contracts COVID-19 and it leads to their death.
I think I'm going to ask Dr. Lynfield to comment first on that, but Commissioner Malcolm here, just a general comment again. I think we've learned a great deal in the last difficult 8 or 9 months, including some of the ways in which risk for severity and even death might be more nuanced or different than we first thought. I think early on we emphasized a great deal, and it does remain true that the majority of people contracting the virus do relatively well or can do quite well. We've learned more about the fact that even for people with mild cases, there may be longer term health consequences than we didn't realize. But in terms of mortality, certainly some of what we knew to be true at first has borne out with time and with more evidence, but we have definitely learned about the disproportionate impact of the disease on certain communities and on vulnerable populations. But Ruth, I'd invite you to comment there too.
Thank you, Commissioner. I agree with everything you said. I think that we certainly have learned quite a bit about the disparities. We have learned that also the disease, and we were talking a little while ago about long-term care facilities, we have a great appreciation for how the infection can enter into a congregate living situation and spread quickly. And it can spread from people who don't have symptoms. And it can result in very rapid declines in patients who are older and patients who have comorbidities. And as we have looked at our data over the course of the pandemic, early on, about 80% of our deaths in April, I think, were associated with long-term care. And now that number is more like 50%. And so we are seeing cases of really severe disease and fatalities occurring in people in the community. And it is true that most of them are older and most of them have comorbidities, but it can be a very severe infection. And as the commissioner mentioned, there are these individuals, some of whom had a very mild case, but go on to develop complications, to have ongoing symptoms for an extended period of time. And I think as time goes on, we are going to continue to learn more about the impact of this virus. The other thing that we are learning is the impact on people's other conditions. It certainly has impacted health care for many other conditions other than being infected by COVID. And that is something that we also need to take into account.
Is there anything that we were doing now, whether it's in long-term care or in treatments, that looking back, we should have been doing in the beginning? I mean, I'm sure there's a lot of things that meet that threshold, but is there anything in particular that stands out to any of you that is something that could have helped early on?
This is Jan again. I'll just make a comment and then again invite my colleagues to add on. I think one big takeaway is we have a fresh appreciation for the fact that the long-term care is a vital part of the whole healthcare continuum. And when it comes to emergency preparedness, when it comes to things like infection control, when it comes to things like personal protective equipment, both adequate supply but also training, that whereas most of the planning focus in prior years has been really focused on hospitals and acute care, that same attention needs to be applied to and those resources available to long-term care as well. So that's one takeaway. I think infection control has been an issue in these facilities for a long time, compounded by staffing challenges and other things. So going forward, we just absolutely have to learn from this renewed focus on infection control in these facilities, build on the lessons that we've learned, and keep it going from here. So, Ruth or Kris, what would you add?
Well, I'll let Ruth comment on advances in treatment, because there are some things that have made a difference in how people are doing with COVID. And I wouldn't call them a lesson learned, but they certainly are an advancement since the beginning. I would say that, probably a lesson learned is just, I guess, to not underestimate the role of public response in the ability to be successful with a pandemic. I think that we may have been a bit naive in terms of the public's appetite for being able to follow what feels at this point, 8 months in, as restrictive guidance. And I think that's definitely a sobering lesson learned. And I definitely agree with what Commissioner Malcolm said about what we've learned related to the role that long-term care plays in our communities. And I'll turn it over to Dr. Lynfield for other comments.
Yeah, thank you, Kris. There has been a lot of work, sort of the metaphor of building the plane while you're getting ready to fly or while you're flying it, in that there have been a lot of clinical trials going on. And I think that there have been advances in the care of patients. And when we look at our data, we do see a shorter length of stay that is occurring during over the course of the months of the pandemic, even taking into account age, because as we were discussing earlier on, we had a lot of admissions and folks from long-term care. So that's good news, better care. And I do think there has been a lot of multidisciplinary work of people all working together. You know, when we come up with our guidelines, say for long-term care, you know, people have really approached it from multiple angles. And I think that there also are similarities in our guidance in other areas, such as school. You know, we recognize the key importance of trying to make in-person learning as much as possible, and trying to break down and make it as safe as possible, and trying over the course of the pandemic, learning which activities really are high-risk activities. And that has certainly helped us refine our guidance and our approach. But this is so hard. We know that people are making a lot of sacrifices. We know that a lot of people have been hit very hard economically. And we also know that there are so many other effects and unintended consequences about prevention measures. But when it comes down to it, really a lot of the control of the virus is these really hard prevention measures. And to look at the success in New York, for example, where they have been able to be under 1% positivity for more than a month and a half is remarkable. And so I think we are also learning from our sister states regarding new ways, new things, refining things, being able really to learn from each other. And I really, really hope that Minnesotans will pull together, because we can and we really need to. Thank you.
Thanks to you both.
That's all the time we have for this afternoon. We invite any reporters with additional questions to reach out to our communications office this afternoon. Have a good day, and we will be back with you again on Friday.
This concludes today's conference call. Thank you all for joining. You may now disconnect.